Welcome to the Voices of Healthcare Equity. I'm Kim Tranquata, the founder and CEO of the Healthcare Alliance for an Equitable World, and your host on this journey. Our organization, driven by clinicians, is on a mission to address global healthcare inequity using telehealth solutions. Together, we're also building a community of healthcare professionals committed to making a scalable impact on global equity. Join me in insightful conversations with healthcare innovators and advocates around the world as we explore the current and future state of healthcare. Be a part of the mission. Let's create lasting change together. Today, I have the pleasure and honor of speaking with my friend and fellow Kings County Emergency Medicine alumnus, Dr. Dara Kass. Dr. Kass is not only an emergency medicine specialist physician, she is a strategic consultant with a focus on reproductive healthcare access in emergency departments. She's also the founder and CEO of FemInEM. Am I saying that correct?
You totally did. Most people don't. You do. So it's great.
Okay. FemInEM, which is an open access resource dedicated to women working in emergency medicine, and the FemInEM Idea Exchange, which is an annual 3-day CME course dedicated to gender equity in medicine. She's also been involved in Time's Up healthcare movement and founded a rapid response messaging operation for frontline healthcare workers during COVID-19. Dr. Kass has consistently worked across her career with government and the private sector to advance equity and diversity in healthcare and healthcare leadership. And she's here today to share some of her current work and her deep perspective on healthcare policy. It's my pleasure to welcome you to the podcast, Dara.
I'm actually, given everything that's going on in the world, which I'm so sure we're going to talk about, I'm really excited to be here and talk about what we want the world to look like, not just what we're reacting to.
Yes, 100%. Before we begin, I always give my guests the opportunity to state any disclaimers or conflicts of interest they need to put forth before we chat.
I don't really have any disclaimers. All opinions are my own and not those of my children. They like to remind me of that. Other than that, I'm basically gainfully self-employed these days. So I'm pretty safe telling you how I think it is and should be.
A beautiful thing.
It is.
That is definitely a big weight. So let's start from the beginning. Not everybody knows you. I'm very fortunate to know you from a long time ago. We won't date ourselves. But tell me a little bit about your background and how you became an advocate and leading voice for healthcare equity.
So I was born in Brooklyn, New York, and I know that sounds like a weird place to start, except Brooklyn is in my soul. And so in many ways, living in an urban environment amongst other people is very much who I am. And then I went to college out of state, but came back to New York for medical school and residency. And my mom is an ER nurse. Or was. She's 79 right now. But I always knew about the emergency department as a place people went to for whatever they needed. And actually, to geek out with you, so my mom was an ER nurse at Brookdale, which is a hospital in Brooklyn that we rotated through in the Kings County residency. So when I got there after deciding to go to medical school and become an ER doctor and training at Kings County, it was really full circle to get to that ER where I was born in that hospital and walk around and be like, you look like a nurse we used to have here, and I was like, oh, that was my mom. So I kind of grew up and I did emergency medicine and I got a job as an attending and started a residency with friends and really tried to make a difference on the education of people around me. And for me, the work towards equity, there's a lot of pieces of emergency medicine, right? We were trained in an environment where the medicine came first, the patients came first. There was not a lot of noise around the kind of care we were delivering. And everyone found their lane, whether you worked in global health or you worked in, substance use disorder. You found something that there was always a piece you felt like you could become connected to, right? For me, that piece didn't happen until I started having kids. And I realized that structurally the world, was so different for women who wanted to become physicians, who wanted to stay physicians, right? So for me, getting into medicine wasn't as challenging as watching people try to stay in medicine. And realizing that society's burdens, specifically around childbearing, but if you add on things like, pay inequity and promotion inequity and biases, I started realizing that so many of the things that had happened to me in residency and in medical school, whether it was like jovial name calling or evaluations that I was like not entirely sure what had happened, like those were super gendered, right? It was because I had a personality that wasn't entirely aligned with people's perceptions of what a woman or a girl should act like. And so I started doing a lot of the academic work around gender and medicine. And fast forward to as being female and, being able to procreate and also getting pregnant and many things related to gendered biology became criminalized or certainly changed in the United States. We started integrating that also into the work that I integrated that into the work I'm doing, because I feel a kinship with the burden of that, but also feel like at this point in my life, I can act as an advocate and as a champion with power. And so I will say that I come to any work related to health equity with the privilege of who I am and the responsibility to know that in any time those tables could turn. So I'm going to use the voice and the power I have while I have it.
Yeah, let's talk about that, Dara, because I have a platform and I'm trying to bring these conversations to the platform. And that's not something I had, 30 years ago. And I think you and I probably experienced a lot of similar things as we became physicians and parents. I became a mother during my internship in residency. 3 months in, I was pregnant already when I was interviewing. In a lot of ways, I think in the past, I feel like we live in a whole different universe right this second. But in a lot of ways, in the past, these issues of equity and treatment of women in the workplace and treatment of healthcare workers in the workplace. I mean, that's crazy. It was much easier to hide them under a disguise of maybe they're not really happening. It's all in your head, a little bit of gaslighting. And as much as I very much don't appreciate where we are right now, I think it really has removed that veil for why these issues are important. What do you think?
Yeah, I think so. This is actually one of the ways that I'll talk about social media. So I think that, when I graduated from residency, in 2007 and, started talking to people, and I was very quickly out of my own bubble, traveling to national conferences, working in education, and asking people kind of what they were going through similar to me, these clearly identifiable landmarks. And what's interesting is like things like getting pregnant, right? Like people are going to still get pregnant. It's super predictable, actually. Yet, everyone acts like it's a surprise. As soon as somebody shows up pregnant and going to have a baby, not only is it a surprise, but it's their thing to figure out. There's no plan. And I was like, I don't understand that. But then as we kind of started using social media, both in education and then obviously to connect, it allowed us to share stories across systems, across hospitals, across states, and across experiences. So you didn't have to be the only intern that was pregnant in your class. You could find a dozen other interns who were pregnant in their classes, and you could start sharing notes about what was happening to you. So I think that as much as what is it? Sunlight is the best disinfectant. I actually think that in this particular case, social media and our ability to connect across the house of medicine really started to allow us to see the stuff that had been living so deeply in silos. And again, we lived in New York City where there were so many residencies and we at least had some sense of connection. But there were people practicing in rural America and in states that were just by themselves and just didn't understand how similar their experiences were to other people. And again, that came with a recognition of time. I mean, when you think about the first residencies in emergency medicine and the promotion of women and how women became at a level enough that they had shared experiences that they could start talking about having some power, it certainly has not followed through to the highest levels of leadership. But there were enough women in like early, mid, and even solid mid-career by the time I grew up that I had enough mentors that I could say, so tell me what's going on there and what things would you want to correct? And so that time also, I think, helped. So the two things I'd say that helped us see through the gaslighting were A, social media and bringing down information silos, and B, enough women at positions of experience that we could collect them and that they weren't worried about being the only one, but they knew that they could kind of keep the door open for other people to follow them.
And I think early on, I was so impressed by your ability to go on social media and share these stories and connect people. I feel like I'm a whole different generation, right? Where we didn't talk. We still don't, right? We still don't talk openly about our challenges. And I think let's acknowledge that that's not somehow a female failure. Women don't talk about their challenges because they suffer different social consequences than men do. Men come back from paternity leave and they're like, oh yeah, I'm great. I'm taking care of the kid. And look, the kid is running back and forth in my video. And if you're a woman, that's a career killer. You don't get the same privilege, right? So you don't openly share your challenges. But I have to say, look, again, I love that sunlight is at least shining on these issues, but I have the privilege of having had 3 kids over 3 different generations. Mm-hmm. And nothing has changed. This is so systemically ingrained.
Right.
That nothing has changed 30 years later. The women going into the hospitals that I work in 30 years later, when they have to nurse their child, have no support, you have to go in a bathroom, the most unsterile place possible. Or on one campus, they said, that's great. We have a nursing room. You sign up for it.
In advance.
But that's a mile across the campus, right? Yeah. So if you go there, you're only going to go there very rarely, and you're going to waste a lot of time, and it's going to make you look like the worst team member possible. Like there is no incentive in place to use any distraction.
So I'll push back a little bit to say that I think that there are some systemic improvements around that experience. Like lactation is a good one, right? So I have actually found that most of the places I have worked have, and what's your podcast cursing policy? I do around a third in. I usually ask this.
I believe they're all adults, and I'm not on any network. So
okay, no. So I'm a bit of a shit starter, right? And so when I get into a place and I look around and I see what's broken, I have a draw to fix it. Like it's part of who I am. And so when it comes to like lactation facilities, like I have given the same presentation about building a room and what does it look like. But now when I come into a department, people ask me, so how do you feel about this space that we have, right? So, and I will say that, the thing about emergency medicine, which is hard, is our spaces are so valuable. And it's really hard to compel people to say, okay, this room that could be used for patient care or for charting or whatever, we're going to now call it our lactation space. So I got to the point where I even started working with facilities on like these pods that you could put in the waiting room that patients or physicians could use, because then it was at least like a corner of land of real estate that was not being used. But I will say that in the past 20 years, since I started doing this, everyone is at least expecting the conversation, right? It is not true anymore that leadership in hospital systems are shocked that you would bring up the idea of lactation or of the idea of needing somewhere to pump or the break. I remember my first job at a residency, everyone smoked. Okay. Like everyone just smoked cigarettes. I mean, this was still, 20 years ago. Mm-hmm. And it was totally socially appropriate for the whole damn team to just go out on a smoking break, right? All the doctors, the nurses, everyone just go outside and have a cigarette. And Yet, if somebody needed to go pump, it was like, wait, what are you doing? You're taking time away from patient care to do something for yourself. And really, it's not for yourself, right? It's for, it's for the health of your baby, but it's, I mean, whatever. So flipping that narrative and saying that even that presumption that it is not appropriate to go and pump on shift is bullshit. Right? The idea that when you show the data on maternity and paternity leave, right? When you show people that men only take as much paternity leave as the guy who is their boss. So if you're a boss, you better take paternity leave because the social construct is the guy who works for you is never going to take it if you didn't take it. But if you're a boss, the most important thing you can do for equity around parental leave in your institution is to take paternity leave. Like, what kind of gimme is that, right? Like, you can be an engaged parent and be a good example for your, the faculty that work underneath you. Like, it's absurd to think that this idea, and this goes back to the historic culture in medicine of I walked so many miles without shoes in the snow, and so you have to as well. One of the ways that we get to a more equitable culture is to reframe a narrative that just because somebody suffered, everyone should suffer after them.
Right.
Right. And so a lot of the absurdity of using your privilege to then live by example and remind others of your peers to use their privilege to live by example as well creates a better environment for the future. And I think we're seeing, the consequences of that not happening, especially during COVID, with the careers of the people in medicine beneath us. It is not common for people to expect to be in full-time emergency medicine careers for people graduating from residency now. Everyone has a plan B. Everyone has a side gig. Everyone's looking to do this job half-time and something else because they know that it's a pretty unsustainable life. And they're not interested in suffering the same way that the people ahead of us were.
Yeah. Dara, I'm going to ask you a question that comes to mind because of where we are now, right? Like, I would never have asked you this question 5 years ago, but
or even 5 months ago, probably.
Or 5 months ago. But let's break it down. Why should people care? Why should we let women become doctors? And why should we let women who choose to become doctors be parents? And if they're going to do that, why should they be the kind of parent that has to nurse their kid and take time off, et cetera?
So I think, society is better when everyone is their best self, whole self. And that's not just true for women. So like almost every reason why we should let women become physicians is because we want physicians who want to be physicians, right? And we want people to be physicians who have the knowledge and the capacity to do that. But we also want to create a world where you don't have to be only a physician, much like I don't want anyone to be only an attorney or only a teacher. I want people to be full humans. Again, in medicine, we did not have that paradigm, right? The kind of, and I say this, the old men of the, 50s and 60s who became doctors, it was their entire identity. It was everything they did. Their entire world like restructured themselves around that physician's life so that he could just be a doctor and everyone else would support him. It is impractical for that to be sustainable at scale, even forgetting the gender of the person. So one of the things I talk about a lot is this idea of like flipped genders for relationships. So if you're in a heterosexual relationship, two, people, one is a physician and one is not, you may have the physician working full time and the non-physician working at home and taking care of the family. Often that was the guy. And then, so the wife would be at home. And I remember a time where I interviewed and somebody told me that he too had full-time childcare because his wife was a stay-at-home mother. And I said, that's great. Thank you for that. Dying inside. Actually, because that meant that that's how he treated his home life. Like that was her job. This was his job. And there was nothing where that should meet. And I don't think that's good for anybody. But then often for women in medicine, the first thing they did.
That's what he expected for you.
Right. No, right. Like he expected there to be one person whose job was the house and one person whose not job was the house. And for years, as women became more established physicians, all they did was flip the narrative. right? So they said, okay, I'm the full-time physician, so you have to be the stay-at-home partner. And from an identity perspective, there were certain guys that were cool with that. But not all were, right? And so you saw this really, like how it shook out in time was that a lot of women physicians didn't stay married, or there was resentment amongst the partnership. And so women physicians were now just not working full time, but now they were not necessarily married anymore because men historically weren't thrilled about being placed into the traditional gendered role of the woman. Now, again, I'm using a lot of presumptions. So then as we saw same-sex couples get married, it was an opportunity to kind of reframe expectations in medicine because, well, if I'm a woman in medicine and I have a wife in medicine, you've hit the jackpot, I guess. But if I am a woman, if I'm a man in medicine and I have a husband in medicine, who's at home with the kids kind of thing. And I only say that to say that those lessons from equity and inclusion. So the idea that as representation grew, there were more lessons for how to figure it out. Right. And for me, the last lesson we're learning, so not just like men staying at work, their wife staying at home, and now women working and then their husband staying at home, or then whether they were two men or two women or whatever. The next lesson was men choosing to be more active partners and actually, even if their wives were working at home or were not, pulling into this equitable home relationship. And that's the change that I actually started seeing in the last, let's say 10, 15 years, where my peer group, the guys that had kids the same time I did, they started saying, well, what about me? Why can't I be a present parent? Why can't I be somebody that gets a schedule that allows me to be at my kids' games, not just because I want to, but because I know that this is my responsibility. And I think that shift of men getting to be whole members of their family is key to us seeing gender equity across the board. I think medicine is in a challenging place, not related to this concept. So I think that there's things that we need to work out regardless. But I think from a gender equity perspective, from your original question about why we want women to be physicians, it's because we want more physicians who know how to do the job. We want everyone to become parents. 80% of the burden on women physicians that is part of parenting is not biologic, right? It's things like leave after the baby's born, which has some biology components, but some not. It has, the idea of being a lead parent historically when their kid is young, and that does not have to be gendered. So there's a lot of things that women had taken on, but don't have to. So I think that we want to create a more equitable landscape for people to become physicians and to be parents. And not to say the data that shows that it's better for patients, it's better for communities, it's better for hospital systems, and it's cheaper to not train and lose physicians of any gender, but keep them in the field so that they can become experienced physicians who can take really good care of patients.
Yeah, so we are facing a looming healthcare worker shortage. And with physicians being sort of at the top of that food chain because it takes so long to train a physician, especially so, we have somewhere between 15 to 25% of physicians considering retiring early in the next 5 years. This has spiked since the burnout epidemic of COVID. Definitely not the time that you as a society want to just say, well, we'll just have male physicians.
And I think that's, yes, true. You don't want to decrease the options in the workforce, but I think there's a lot also about forced choices, right? So and I've had this conversation with some young physicians who are new parents, here I am, I'm a young mother, I'm working so hard to stay at work, I'm nursing, and I go to work and it's traumatic, right? It's like, not just that I'm fighting for the biology aspects of being a new parent, but I'm also in a really poorly sourced clinical environment. I feel like I can't get ahead of my patient's needs. My leadership is not supportive of me. Why would I stay? Like, what is it about the house of medicine that is keeping me? Because I have other things I need to be doing. And so I think there are many more systemic issues around keeping physicians in medicine than have anything to do with gender or biology. And especially as physicians get older, one of the things that, kind of not to jump around, but when I was in the federal government, I was a regional director at the Department of Health and Human Services for 3 years. A job I expect by the end of today won't exist anymore, to be honest. At least the one that I had should be done by 5 p.m. today. I wanted to think about, could we allow physicians to retrain in other specialties, giving them credit for the careers that they've had, but not giving them the only path out. So saying, you have been an emergency medicine physician for 30 years. You don't want to do it anymore. There's a lot about the trauma of being an ER doctor or the schedule or whatever, but you would love to go work in a clinic. Don't get me, so I could do a whole podcast on the Pit, right? I really could. I think it's the most important show on TV today when it comes to reforms of healthcare. I
squirreled you away. Go back.
No, but it's the same thing, which is to say that when you see the toll that emergency medicine takes on people, you realize I have a skill set that isn't just related to what I can do in an ER, but I could be an addiction medicine physician. I could be a pediatric something. I could do so many jobs in the house of medicine that are useful to society because we don't have enough primary care providers. And the speed and the adrenaline and all the things that dropped me into emergency medicine when I was a kid, I don't need those anymore. I'm good. No, I got a busy life. I got a lot going on. So could I do something else that would be better for my life, that would keep me in medicine? And we have never said that to physicians. Nurses can change practice environments. PAs can change practice environments. But because we invest in physicians the way we do with federal dollars under GME, and we train them in residencies at federal cost, we do not allow them to be anything but the thing they decided to be when they were often 22 years old.
Love that. Great idea. Okay. Why don't we have government-sanctioned ability to pivot to a related or similar area of medicine as PAs, nurse practitioners, and nurses do in the healthcare arena? Dara, tell us more about that.
I'm going to frame it to what government is really good at and what it's not really good at. And this is a good time to, I think, talk about that with what we're seeing around us. And I think especially when we talk about equity and we talk about progress and we talk about, investing in programs, like where do we really want to see the return on those investments? So the government's really good at, government it's important that government is around to ensure that there is fairness and then more importantly, that there is opportunity for things that are not necessarily profitable or that are, risky. There's a lot of reasons why government needs to help it get things started. And also government does things across systems that that are not, that you can't depend on one system to advance, right? So when you think about graduate medical education, the government works nationally to advance the investment in future physicians in service of the country, but does it in partnership with institutions. So how that's executed in the federal government is actually in a few different places. And so the problem with that is if you want to change it, you have to kind of align different parties that are not necessarily used to working together, right? And so when I was in the government, I watched the investments in the healthcare workforce. So this all became because we started talking about the shortage of primary care doctors, which is kind of what you were talking about, right? The burden of there are not enough substance use counselors. There are not enough primary care doctors. We're going to invest in psychiatrists. We're going to invest in primary care pediatricians or whatever the need is, right? Rural physicians, rural healthcare is in crisis. Rural hospitals are closing. And I looked at the investments in new healthcare workers, right, from scratch. And I'm like, wait, you have all these programs that are doing loan forgiveness and they're kind of recruiting into rural communities, new doctors and the pipeline. And I'm like, wait, but what about all these 20%, like you just said, that are already trained as doctors? And all you need to do is give them a tweak and they could go. Why are we sitting here only thinking about the pipeline from the beginning and we're not thinking about the divergence of the people that are already expressing a willingness to change? who could talk to those people about what they want to do and offer them pathways to do something different that aligned with what the community need. I mean, what people need. This is a whole other conversation about how we create physicians is related to what hospitals have room for and what people want to invest in. We don't, as a country, say we need this many psychiatrists, primary care doctors, pediatricians, family medicine doctors, and that is how our workforce is created. It's created not from the top down, but from the bottom up. So it's a groundswell of positions that are created and supported, and we hope that it all fits what we need in the end. Right. And even along the way, there's no tweak to ensure that what we're getting from the churning out of physicians matches the needs of what communities have. And so I just looked at the whole system and I was like, could we do something better right now? Because we're in a crisis for healthcare workers. And again, when you go back to things like equity and access to healthcare that is necessary, you find the most vulnerable among us have the hardest time getting a physician. But if you want to be a fee-for-service patient for a plastic surgeon in an urban setting, there's like 6 you can see on any one day. Try being a psychiatrist, a patient who needs, mental health help in a rural community in Alabama. And I don't know that you can find somebody who takes your state Medicaid that you can see in a reasonable amount of time. And so these are the kinds of things. And I think this also goes back to telehealth. I came to telehealth as a evangelical, if you will, because of gender in medicine. Mostly because as an emergency physician who watched women through their careers get more pregnant, and women age out or people age out, right? If you broke your leg in the ER, you had to be out of work or you were scooting around, but your brain is fine. Like from neck up, you're all good. Why can't you just sit in front of a computer and do telehealth for 6 weeks? And at least then you're still useful to patients and you're doing your job. Like the lack of flexibility for the physicality of our work environment became a burden. And I was like, but telehealth can cure that, right? And in the pandemic, you saw that even more because in a world where you want to contain infectious disease spread, everyone going into a room and doing telehealth meant that patients could communicate with doctors and everyone was safe. So having that said, the expansion of telehealth as a practice and the opportunity for different specialties to use it allows for flexibility for the workplace. But it also requires, specialties to evolve and to say, okay, emergency physicians, how can you use telehealth in your practice? Orthopedics, what would you do to use telehealth in your practice? Because you can get to more patients in more remote areas with the knowledge that you have. And how could you hybrid that? And so these are the things I think about when I think about the system writ large, because there are better ways to do a lot of the things that we're doing. Having that said, breaking the whole system without a plan is not one of the ways to get there. Is that fair?
Indeed. And I know you because you are a recent government employee, you're walking that line there between the role of the government and the private sector. One of the most important roles of the government is to care for the underdog, because otherwise the system just becomes one that promotes those that have more and more and more, right? You make money for us, we invest in you, you make money for us. And then more and more people fall into the have-nots, which is, what we're sort of seeing in our society, right? There's a growing economic gap that keeps growing. And one of the roles of government is to say, we want to be a peaceful civil society, and big gaps in opportunity create unrest. This is what causes revolutions. This is what causes war. And so in order to have a peaceful, safe society, one of the things you do is try to build equity into your civil society. And somebody has to take on the role of taking care of the people for whom it's not profitable. Everything can be based on profit.
Well, I think so I think about this a lot. I mean, in that, in a lot of what I do, and actually this is even a decent pivot to reproductive health care, right? Mm-hmm. Because, so I'm a capitalist, but I'm a capitalist with rules kind of girl, right? So I believe in capitalism. I believe that you should be rewarded for working hard. Innovation is fantastic. Entrepreneurship. I am somebody that has a lot of entrepreneurial drive, and I enjoy seeing the rewards of that. I also fundamentally understand that that there are many, many things that are not supposed to be profitable. And honestly, the delivery of healthcare is one of them, right? The whole idea that people are consumers of healthcare as a customer base and that they can make choices that are both driven by economics and affordability is absurd, right? So when you need a transplant, that is not because you've saved for that transplant. It's because your liver has failed. As the mother of a child who had an organ transplant, I don't know what I would do if I had to look at the landscape and say, okay, now I got to go to the store and I got to buy the medication that he needs for his transplant before they'll give it to him, as other societies have. Like, I think many Americans don't appreciate what our system actually does have as far as equity and access, and what it looks like to even tear that down even more, but what it even looks like in other societies that have more access, and how great it is to know that you can go to a hospital, get cared for, and not come out with a $12, $15, $150,000 bill that could make you bankrupt. Like, there's so many pieces of our ignorance to what this healthcare system actually does, and also what it could do.
But we're going to pivot into reproductive health care anyway. So we were talking about the role of government and whether it's all just, based on, money or profit, and what's the role of taking care of who can't pay and all of that.
Well, so that's what I was saying. So the profitability itself, right? And this is the venture capital private equity model, right? You go into a investment with the return on capital, right? Money to come out. We saw this with reproductive health care with some of these innovative programs that were solving a problem. So as we lost Roe, so as abortion access nationally was no longer protected, and as organizations started trying to fill the gap, whether it was telehealth access for contraception or for, medication abortion, or even helping people travel across state lines, there was columns that were taken care of by philanthropy, columns that were taken care of by governments, not the federal government, but state governments. And then there were columns that tried to be taken care of by investments. Would you see a private equity investment in a new telehealth organization that might be able to deliver a service? The problem is reproductive health care, much like a lot of healthcare that is not frivolous, and I don't mean to shame or blame on the healthcares that are profitable, is not reliably profitable necessarily. And so, especially when women are in first trimester pregnancy crises or first trimester pregnancy issues, when they're having miscarriages, when they need to maybe terminate a pregnancy and they're, figuring out how to do it, you cannot charge them the highest price. Right? The business model doesn't work. Often they are low-income people. They are often people of color. They're often already parents. They often don't have insurance. And so the idea that you could increase the price to meet the customer need, which is what capital markets do, right? I have a thing that somebody needs, so I'm going to charge the highest price I can get for that product. Well, if that product is, medication to terminate a pregnancy, and now you're holding hostage the person that needs that. I mean, that is not where markets should thrive, right? That is where governments should thrive, right? Healthcare systems that provide access to a healthcare need that somebody has, that is an investment in the future, which includes the health of the pregnant person who no longer wants to be pregnant, the health of their family, their children's, the existing children who need to have a family that can survive. And so for me, when I think about the role of government, the role of equity, the role of access, the role of investing, I want to make sure that we're looking to the right support systems to keep the right care access afloat.
I want to bring this back a little bit. I recently had a conversation with someone about why these laws are actually impacting women in a way that's about more than just having abortion. So lots of people are anti-abortion. They don't believe in abortions for personal reasons, right? And a couple things. you were always allowed to make your own personal decision about whether you would have an abortion or not have an abortion. That was always the case in the past. But there's a little bit of a crossover where there has been a lot of misinformation about the rate at which people are having abortions and what stage they're having abortions, and a lot of public distrust that the same doctors that they trust to take care of them in emergencies are somehow doing mass murder of babies after birth. A little inconsistency there, but again, there's the idea of abortion, and then there's the idea of what abortion laws are doing to women across a whole spectrum of reproductive care that does not just rest on you're going to carry a pregnancy to term or not. It is impacting whether women who have ectopic pregnancies or ectopic implantations, it's affecting whether or not they can get health care to remove something that was never going to become a baby or a fetus, and indeed endangering the woman's life and making it less likely she'll ever have a baby. A lot of these women want to have babies. This isn't about women not wanting babies or using abortion as contraception. And then there's a little bit about the language that are written in these laws. These laws are written in the most obscure way so that physicians can't make a medical decision in a medical emergency. And instead, everything is sort of vaguely part of the law. And your doctor has to choose between, are they going to now leave their family and go to jail, or just wait long enough and hope that this woman doesn't die and they can catch her in the midst of this emergency. Can you talk to us about what this is doing to real life people? Because women do not understand this. Women, men, people think this is about, and we don't have to go into any of those assumptions people make about abortion. But
let's go back to a lot of that, because that's a lot. And I think that we could do an entire hour on access to reproductive health care in the United States, even in just only talking about emergencies. First and foremost, the good and bad abortions is what I talk about, right? So termination of pregnancy for good reasons, termination of pregnancy for bad reasons, whether or not the person who is weighing in agrees with the motives of the person who is having the termination, right? It is 100% true. So the collateral damage of abortion bans is another term I use. So that has to do with the idea that decision-making becomes more complicated, not for medical reasons, but for political or for legal reasons in states that have put restrictions on access to healthcare procedures that had never happened before. So we were not trained in a world where you had to have near certainty on ectopic pregnancy existence to offer somebody treatment for ectopic pregnancy. There's a whole window of treatment for a time of pregnancy called pregnancy of unknown location, by which somebody has no evidence of a pregnancy in the uterus, but we think they have an ectopic pregnancy. We can offer them pregnancy, treatment early, so termination of pregnancy early, consistent with treatment of ectopic pregnancy. Is there a possibility, has there ever been a possibility that could have been a normal pregnancy, but the person who was pregnant didn't want to wait 2 or 3 days or 5 days or 7 days, but would rather end this pregnancy and start over again? That was always their choice. Now we're seeing in states with restrictions, those choices have to be defined differently in an absolute paradigm that we never created in medicine, right? And the way you talk about the laws and how we interpret them as doctors, they are not written for physician execution. And I have been spending a lot of my time now working with attorneys to translate those laws into language that, for example, emergency physicians can understand. So one of the terms that I have literally coined is potential for viability, which does not exist anywhere. When I say to you, Dr. Tronquata, that pregnancy has no potential for viability, you kind of know exactly what I mean. right? That is a miscarriage. That is a patient who has rupture of membranes at 16 weeks. That is a patient who has an ectopic pregnancy. There is no chance on earth that pregnancy is going to end up with a baby born in a mother's arms starting to nurse, right? There are lots of other complications or kinds of pregnancies that could be traumatic, fetal anomalies. There's so much devastation when it comes to the process of being pregnant that does not incorporate. But from a first trimester pregnancy decision-making framework, that makes sense to me as a doctor. And it encompasses almost all the exceptions that exist. So when I talk to doctors, I give them that framework to say, you need to start thinking about potential for viability. If you're in front of a patient and there's no potential for viability for that pregnancy, you act. Because every law across the United States, it doesn't take into consideration how and why the person got pregnant. So whether there's an exception for rape or not an exception for rape, that's not relevant to your clinical decision-making right now as a physician in that moment. All that to say that for us as ER doctors, we need to ensure that patients who come to us do not have adverse outcomes beyond what the law is requiring. I cannot change the laws in many states. If the law says that we cannot act until the patient has, some mandatory evidence of sepsis, that would be one thing. But actually, none of the laws say that, right? A lot of them say reasonable medical judgment. A lot of them say, they leave actually a fair amount of leeway for the physician, and yet nobody trusts the lawmakers. They don't trust the politicians. They don't trust the attorney generals. So everyone is chilled and they're doing less. And the one thing I will say to you, and the one thing I'm talking about now across the country, and this is the new equity, right? This is the new thing. I have now, instead of half the population of physicians where I'm trying to keep in the workplace, I am now trying to keep half the population of the United States alive. And it's a little bit of an over-exaggeration, but it's not. And what's kind of incredible is that we don't have a huge place in this world of pregnancy continuation or even termination of pregnancy. We have a very small piece of it, but the piece we have is life-threatening often. The piece we have is urgent. Somebody ruptures their membranes and comes into an ER at 14, 16, 18 weeks. You have to be the one that is their champion. There is nobody else, right? And that has been true in emergency medicine for so many other activities. They come in with a heart attack, that's on you. They're having aortic dissection, that's on you. Right? They were hit by a car, that's on you. So from now on, they're coming in with rupture of membranes at 16 weeks, that's on you, right? We are the ones that have to advocate for these patients to ensure they're not inappropriately discharged and sent home to get infected. And so my role now for the next year or so through FemInEM is going to be to travel the country and talk to physicians about emergency physicians, our people, about this role, because women dying in our parking lots is so bad for our brand. Like it is, right? Why would you come to an ER if all they're going to do is put you back into the parking lot and let you just bleed out? So let's let people come to us for care and let's actually deliver it.
And they're dying at home. Women are being young, women that want to have babies. I have to say this. This isn't about women. Women want to have a baby. You have your pregnancy implants in the wrong place, in a tube where it can only rupture and it can never become a baby. And you're sent home because that implantation, it's not a pregnancy. It's just it's an implantation, is not clearly not a viable pregnancy to whoever is interpreting the radiology at that moment.
And let's be very clear for anybody listening, ectopic pregnancy is treatable in every state in the United States. 0 patients who have diagnosed ectopic pregnancy should be discharged from the ER without treatment, unless for some reason that's a decision that you have made with your patients and with your gynecology consults.
Yet it's happening.
I am here to tell you about the future, right? We're talking about the future, a future where patients do not get discharged from the ED inappropriately because people do not understand the law.
Yes. So let's talk about what could be. If you could ask for anything, I guess especially now, what would you ask for? And who would you ask to help you make progress on reproductive equity?
So the first thing I want is kindness and grace. Like I want people to start seeing other people as people. Like, I want those of us to understand that judgment and bias and the idea that somebody is good or bad because of choices that they have either made or have been made for them, which includes who raised them, right? And their education that came, like, we need to let go of our, and that's true across the board, but right now, especially with reproductive health care, just because someone lives in a state with abortion restrictions, it doesn't mean they deserve to die, right? Just because somebody lives in a state that is like a blue state or without restrictions, it doesn't mean that they are required to, change the world. Although, and they're not required to save the world, right? I would like to get politicians out of our exam rooms, and I would like to create a world where being pregnant is that everyone in America gets pregnant because they want to at a time when they're prepared to. If they get information during their pregnancy, they can treat it accordingly. And that is the only thing we think about. Like the idea that, people you cannot create bright lines. This is too complicated. It's always been complicated for hundreds and hundreds of years. It was complicated. Women died in childbirth because it was complicated. They died of ectopic pregnancies before we had the ability to diagnose. And the last thing I will say is I don't want technology to get ahead of our ability to take care of patients. So many of the laws, the restrictive laws that are being written because of our technology, like heartbeat bills, right? The idea that you can, like quickening, which was 18 weeks, right? With how you could determine whether or not, or 14 weeks or whatever it was, that's how you knew pregnancy before. Most miscarriages occur before that. So you never would say to somebody, oh, you intentionally ended your pregnancy. You didn't even know you were pregnant. You just started bleeding, right? And then you had a miscarriage. Because we have technology that can diagnose pregnancy so early, we are now burdening women with the idea that you're required to stay pregnant even if you're not meant to stay pregnant. And now we're seeing criminalization of miscarriage so frequently in the United States. And that goes back to kindness and grace, right? If somebody in the United States is terminating their own pregnancy because they have no other option, look to what they needed before that, and let's create a system that other people have it, right? Instead of criminalizing people who literally have no choice, let's look to the system that they live in and say, how can we make it better for the future? I don't know how many people out there think that people choose to continue to have miscarriages as a way of contraception because they have better options, right? Even in a world of bad beliefs and believing the worst of people, right? Let's have a conversation about intentional pregnancy and contraception with patients in our EDs and say, are you interested in becoming pregnant? And do you want to know more about contraception with every patient who has the capacity to become pregnant in our EDs? Let's start with that, so that maybe we'll see less people getting unintentionally pregnant. And again, just because you don't intend to get pregnant doesn't mean you don't want to stay pregnant, but we want to give a chance for people to have intention about whether or not they choose to become pregnant. And we can start that in our ERs.
What a great place to end. I think that's the answer to a lot of things. Be kind, be curious, be graceful with other people. No one wants anybody in their business, but many people want to tell other people that they should live life and make the choices that they have made. And I think the secret to that is curiosity, is trying to understand why they are making a different choice than you. And going into that with the assumption that people really are all trying to do the best they can with what they have.
Right. Yeah. I think empathy, kindness, and grace go a long way. And I think we've really, and we've given up. And again, I think that empathy, kindness, and grace are a really good foundation for things like equity and access. Because again, like a world with inequity, inclusion, and exclusion, like what is that? Like we're excluding people and we're creating a world of inequity, of homogeny instead of diversity. Like I'm not interested in that.
Well, it's almost a revenge. And what we know is revenge does not make people happier. What world do you hope to have if you don't actually trust your physicians? Right. You don't actually trust your neighbor. You don't trust women. Half the population, the women in your life, you don't trust them. You believe that they are ill-intentioned. And you're going to keep them from doing those ill intentions by doing things to get in their way. That is not a world I think that any of us want to live in.
Yeah.
So, Dara, thank you. Thanks for being on the podcast. Any way I could support you, I'm wishing you a wave of champions behind you to carry forth this very important work. Half our population is relying on you to help keep them alive and safe. And that includes all the women out there that really actually want to have babies and want to raise them and be safe and happy. They are going to have a pregnancy complication. It's just statistically, that's the way it is. So thank you. How can our audience connect with you? That's very important.
So FemInEM has a website, www.feminem.org. Take a look at it. We are helping organize a conference for women in medicine in September. It's called the Power of Women in Medicine Summit. It'll be linked on our website. And really just follow the best to do right now is follow our LinkedIn or Instagram, because we have articles and all kinds of things that just really talk about both gender equity and reproductive health care in the United States.
You've only gotten a taste of how complicated this is. Please follow Dara and FemInEM to really get some more insights and stories from women that are actually experiencing all the things, and to get a better understanding of why we need you in this conversation. Listeners, please, we need your support. Please share today's episode with a friend. Leave us a review, share your thoughts, and if you're interested in being a guest, email us. Visit https://haw.org to learn more, join us, partner, or contribute, and let's amplify the conversation for a healthier and more equitable world. Thank you, Dr. Kass.
Thank you so much for having me.